So let me tell you what we've learned about Canada, and then Carol can run us through the rest of the agenda when she's back. Um, so Canada has three different models of safe consumption sites, and they have 39 of the first model, which is a fully licensed I'll admit, Dr. Letourneau, fully licensed consumption site. And the second model is what they call the urgent public health needs sites, and those are more time limited. Their scope is somewhat limited. Their reporting requirements are less. I think that these came into existence, if not during the pandemic, then shortly before. But there's not much question about what those sites are treated a little differently than the more permanent sites. It's a lower threshold, but they can do in those sites everything that just about everything they do at a safe consumption site. And then there's a third site, and this will be confusing for us because the third model is what they call overdose prevention sites, which we almost use for an overall term. But those are sites that operate without any federal exemption, uh, either under a provincial order in response to a public health emergency or without any approval at all. So in some contexts, they consider these to be just uh, operating without any authority. Um, those, to my knowledge, are much smaller than the number of sites. We've taken a look at where these 39 safe consumption sites are, which are operated through an exemption to the Controlled Substances Act in Canada through Health Canada, but the authority is also relayed through the provinces and territories. So it'd be almost like our federal government giving states the authority to authorize these, and a lot of the level of regulation is done at the provincial and territorial level. We have tended to focus on looking at sites um, in the Atlantic provinces for obvious reasons, because they're closer to us. They're more like us in a way if you look at New Brunswick, for instance, but also Quebec uh, and on Ontario. And we've been able to, through really responsiveness to our questions and uh, needs, the people at Health Canada have been just terrific. And so there's been kind of a flurry of activity and communications to the point where we were able to get uh, Christine and Megan, who are involved with the site up in Cape Breton, to present even today. That was only lined up about 48 hours ago, but we do believe that they're going to join us at 2 o'clock to tell us what they've learned in 2.5 years of that site, and and to answer questions about it. Um, I also have spent a lot of time with this document that was sent to you with the agenda, but I don't think it's fair to ask all of you to wait for it, frankly. So it's about a 90-page document with 40 pages of footnotes, and each of those footnotes is well cited and takes you into another other documents. And it's the document's about 18 months old, and it's titled National Operational Guidance for the Implementation of Supervised Consumption Services. And it's loosely based upon a similar document that was done just in the province of British Columbia. But it's very it's very well organized, and I've spent I can't tell you that I've read every word of it, but it's a great way to learn about how Canada regulates these these three models of consumption sites. So the site we're going to hear from today, by the way, it is not one of the 39 safe consumption sites. It's one of the urgent public health needs sites. And those sites, to my knowledge, have all been authorized until September 30th, 2025. Now, what happens after that, I don't know. But I know that this site has operated for 2.5 years. I thought it was a pretty rural site. I mean, it's Cape Breton, but it turns out that Sydney in Nova Scotia is on the east side of the island, and it's got 30,000 people in it. So that's bigger than Augusta, slightly smaller than Lewiston, Auburn, but it does serve a very, very large swath of Nova Scotia. There are other authorized sites in Halifax. In New Brunswick, there is only one site in Moncton. And that is, again, a permanent site operating as a safe consumption site. We have kind of focused our attention on anything that might be mobile and anything that might have a telemedicine or virtual presence, because I think that our solution in Maine might well be something that's really uniquely Maine and would not look like other fixed sites, but the goal would be to achieve all the undisputable benefits of keeping people safe when they use, but actually would not look like a traditional safe consumption site. Now, I'm just telling you, I'm just thinking out loud. We're doing this journey together, and we'll be reporting soon to the Criminal Justice Committee. But I do think that we're getting the kind of information that suggests to me that somewhere in this world there are probably some activities going on that might, in fact, be helpful in Maine. All right, I've got to let some people in the waiting room while Carol's not here. Okay. I don't know. They're not showing up now. Well, Dr. Letourneau, can you help me with that? Do you have any authority to let people into the meeting?
I think I do, unless you make me co-host, Gordon. The other thing you can do is go down to participants where it says the number, and then down at the bottom, you can.
Okay, I've got invite. Maybe that will do something.
Oh,
No.
that's weird.
No.
Usually there's a you can turn off the waiting room. Oh,
Oh, here it is. Okay, I can admit all. Okay. Yeah, I just did that. Here they come. All right, apologize for that interruption. So let me see what else. The other site that I've focused in on somewhat is a site in Ontario, in Ottawa, because it's virtual. That a lot of what they do is monitored, but it's done virtually. So it's akin to, we've already authorized the one of the Never Use Alone hotlines called Safe Spot out of the Boston Medical Center to answer calls from Maine. And it would be almost like those kind of calls, except they would be like telemedicine, telehealth. You would see the person as well as talking to them. So we may be able to get a presentation from that site in Ottawa. If you also wanted do a deep dive into this. If you simply Google safe consumption sites, Canada, they have a dashboard, they have all their data. For the data is split into two pieces. They started getting data reported in 2017, and then, but they had no standard form for the sites to submit that data. So they got a uniform reporting system together in 2020. So when you go to that site, you see 3 years of data, 2017 to 2020, and then from March 2020 to the present time, there's a different set of data. And just to give you some idea of, and these to my knowledge are just the safe consumption sites, not necessarily the public urgent public needs sites, but they've had about 5 million visits, responded to 60,000 non-fatal overdoses, and have about 400, and have had at one time or another about 467,000 clients, and made 1.3 million referrals to other services, HIV testing, hepatitis tests, medical care, etc. Only 1% of their cases are under age 20. The federal government, the national government, does not have a minimum age, but some of the we probably find and learn that some of the provinces probably do. And that's something we want to ask Chris and Megan about today. Not surprisingly, the largest cohort of by age is age 30 to 39. That represents 34% of those 467,000 clients. The most commonly used drug is fentanyl, but even that's slightly less than 50%. Meth is 20%. And then hydromorphone, which is dilaudid, is 11%. Heroin is 4%. I was really surprised. Cocaine was 1.9%. But like I say, any of you, it's pretty easy to get to that data. Almost all the sites seem to report data monthly, and they report a great deal of data, but also strive not to report any personal health information. People can register anonymously, anonymously get a number. So while there's a lot of data on age and demographics, there's, they really try hard to protect people's confidentiality for obvious reasons. There seemed to be a lot of emphasis on these urgent public health needs sites. And I think that was particularly because of COVID, when people were not going into sites, traditional sites. And that's why they really set forth a process, as I understand it, where each province had the authority that they could get these almost pop-up places without at a pretty low barrier. It was interesting to me to learn that Health Canada does not fund any of these sites. I think, again, it would be like our federal government authorizing states to do this, but not giving the states any help to do it. How they're financed, I would guess they get some provincial help, I would think. And I bet there's a fair amount of private funds that go into them. And again, I should have noted, we've also been in touch with the primary author of this guidance document. And one of the organizations that was the principal organization in putting together this document is the Canadian Research Initiative in Substance Misuse, CRISM, CRISM they call it. And it's a national network of researchers, service providers, policy people, and people who use drugs and people who are in recovery. So again, I got a lot out of reading that report. It was sent out to all of you with the agenda today, so you can certainly take a look at it yourself. But I think we'll get a lot more out of just talking to some of the individuals. Carol is back. I'm happy to take any questions about our deep dive into some of the Canadian sites. And this is all kind of preliminary to talking to our friends from Cape Breton at 2:00. But anybody have any questions of my brief report on Canada? Rachel.
Yeah, thanks. Sorry, I'm a little late, everyone. How much of a sense I cheated and I went to that report and I just did the word find for rural and I only got 3 hits. One of them brought me to, 3 findings within that large document. One of them brought me to an article about rural safe consumption sites in Canada. So I read that article and it was based in 2 cities which had populations of 90,000 and 120,000, which was, I guess, by British, by BC terms, was considered rural. So I couldn't find that much in there. Did you get a sense from them, maybe that's just more on more of these virtual resources, but any other models or modes of transportation or outreach or engagement that you heard from Canada that spoke more to an outside of a mid-sized city kind of population?
Yeah, there's a couple sites, apparently at least 100 miles north of Edmonton, Alberta, that I read about. And there's also some mobile sites. And I think what we're really interested in finding is some place where an entire population of an area can be served. And I don't think you can do that with given that the issues with transportation. I think you'll find that they're using mobile vans and making stops along the way, or they may be doing something virtually where they're able to have medical personnel observe people use in their own properties.
Mm-hmm.
So that's what we're trying to look for. But you're right. I mean, even in the case of Cape Breton, I said, "Oh, well, that's going to be perfect." But again, they're in the middle of a city with 30,000 people.
That's great.
Other questions, and we'll step back here for a minute. Let me make sure there aren't other questions. Then we'll have the people that came on after we've done introductions who are on the working group. I want them to introduce themselves. But any other questions about what I've said? All right, and thank goodness Carol's back. But Dr. Solitaroff, why don't you introduce yourself and then Lisa?
Sure. Sorry to be late. I'm Rachel Solitara. What am I? I work as the doing substance use disorder services with Penobscot Community Healthcare in Bangor and also in Belfast, which is what feels much more of a rural area than Bangor. And then also have work as the medical director for withdrawal management at New Horizons in Hamden and down here at Milestone Recovery in Portland.
Thank you. Lisa.
Hi, Lisa Letourneau, an internist by background, have done SUD treatment for a brief time in the past, not currently, but currently serve as a senior advisor in the Commissioner's Office, where I work closely with Gordon on clinical aspects of the state's opioid response.
Dina, I see you with us, but not on camera.
Hi, apologies. I was eating and it wasn't pretty. I'm Dina Livner, Assistant City Manager in Portland.
Thanks so much, Dina. Carol, I think we've introduced everybody that's on the working group. I said what I want to set up the situation in Canada, so I think you can proceed with the agenda.
Thank you so much, Gordon, and apologies everyone again for having to step out to deal with a heating and plumbing issue, but all is resolved. So I wanted to do a quick overview. I made with all the flurry of changes in our confusion about Eastern time and Atlantic time, as you probably figured out. We changed the agenda twice, and I didn't make a final tweak that I just wanted to first make sure everybody realized, which is that we are ending this meeting at 3 o'clock. We are not ending it at 4 o'clock. So the very last agenda item says next meeting, next steps at 3:50, but that's really 2:50. So I apologize for that. It was just one of those things where we were talking to the folks in Cape Breton and we were just throwing around times back and forth. And it wasn't until, I'd sent out the agenda and I went, hey, I wonder if they mean Atlantic time. So sure enough, it all worked out great. So, so that's good. So otherwise, I think the agenda that I've sent you is, the one we're going to try to follow. Clearly, we're mixing things up a little bit. And again, I appreciate your flexibility on that. Gordon,
Carol, I'm going to interrupt just for two things.
Yeah.
I want Scott Stewart, Chief Stewart, to introduce himself.
Sorry, Scott Stewart, and the Chief of Police of Brunswick, and I'm representing the Maine Chiefs of Police Association.
Thank you, Chief Stewart. And secondly, one reason that we will be done exactly at 3 is that Carol and I have a call with government officials in Quebec province who want to chat with us before they suggest what kind of a presentation we would receive from some of the sites that would likely be in Quebec City or Montreal. But they were able to set up that call very quickly for 3 o'clock today, so we want to take advantage of that. Okay, Carol, back to you.
Good. Thanks so much, Gordon. Did you happen to give folks a little bit of an overview of some of those potential speakers on the 7th?
No, we did not. We did not do that at all.
Okay.
And at whatever time, I'm willing to engage in a bit of discussion about where I see this going over the next month. But we can start that at any place that you'd like.
Okay. Well, then how about this? I would like to go to what is written as the 110 item on the agenda, which is an overview of the outline of the report. And then once we talk through the outline, and I want to get your input, and believe me, this is intended to be a super high level version of an outline. It's the things that we've been already talking about in terms of big categories. A lot of it, Tessa's document is going to helpfully populate, some of those categories. There's probably going to be a few more categories we would add in there. So I want to hear from you if we're thinking about it the same way in terms of what the content is that we're going to send back to the legislature. And then from there, start looking ahead and saying, okay, we've got a meeting on February 7th. We've had a lot of people say yes to being available. Let's make sure we have, we prioritize the right cohort to come in and speak with you all. And then what if, how do we use the time on February 14th? So that's how I'm thinking about it. So I'm going to start by just screen sharing the outline, and then we can take it from there. And I haven't tried to make this fancy. I'm really just trying to make sure in this, sort of real-time discussion, are we thinking about this the same way so that we can be tweaking it accordingly. So most reports back from a legislative resolve back to the legislature involve some sort of standard components. So in addition to sort of, an early index that says what's in the report, they often have an executive summary. Then there's an introduction, which gives legislators the resolve itself as a recap. And then they provide some basic background. So I call that, in this case, the situation overview. That could be a data snapshot, for example, sort of how did we get here? Who are we and how do we get here? And then this would be also a chance to say there's been some prior legislation. Here are some themes from that from the public testimony, what we heard. Maybe there's a bit about what the legislators who introduced the bills were thinking at the time, to the degree we know that. And then, that just sort of sets up okay, now this group was formed. There'll be a list of the group members, and then here's what we delved into. So from there, you would have the areas of inquiry, which we identified in our first meeting, and we are following roughly in the way we laid it out. What I've done here, and I want to really talk about this in detail, is to make sure that you think our areas of inquiry are matching both what we intend to do by the end, but also does it really show the full breadth of what we really should be digging into. So we've talked about authorization, we've talked about statutory barriers, but then what we really didn't lay out in the initial outline was the setting. We talked about it, but we talked about it as models. So I was thinking, for the purposes of articulating what we've been working on for policymakers, for legislators, who most of whom won't have listened in to most of these meetings, we actually talk about the types of settings that we've been digging into and looking at. Then we talk about the scope of services, the potential outcomes, and then I'll get into this next part of innovations. So you all, if you're looking at the first or original list, we did call out mobile sites. We called out this idea of hotlines, but really they kind of got meshed together. So I just wonder, let's just start with the question of, do you like the inclusion of a category under areas of inquiry, a category called settings? And then do you think that these three cover it, or is there more? So we've got fixed versus mobile. We've got standalone versus integrated. We've heard a lot in Canada about their integrated models, which Gordon probably briefed you on just now. And I think there's some exciting ideas there. And then we've got permanent versus time limited, which could go up under authorization. So this may not be the right spot for it. But in general, when you think about the settings that we're considering, are we missing something? Should we be trying to find additional information for you all to explore under the category of settings?
Have you really captured the idea of virtual? Because I don't think we have. I would add, like, I agree, fixed versus mobile, standalone versus integrated, and we really did not get into that too much in my briefing earlier, Carol. And then virtual versus in person. That captures what I'm looking at. And by the way, folks, the integrated models in Canada simply means that they're not freestanding. They are part of a health care facility. They're in a hospital. They're in a primary care practice. It's not standalone, and they have quite a few integrated sites.
And also, for those that haven't heard of this, they have some integrated sites with pharmacies, which I thought was really interesting. And we haven't gotten too much detail about that, but the Anna Roberts, who Gordon and I spoke with, she was an amazing resource, and she talked about creating she called it a chill space, but a chill out space in between the main part of the pharmacy and the OPC, and the importance of that. And it allows for these integrated sites to work really well with other types of entities. So fascinating. Dina?
Dina has raised her hand.
Thanks. I might have missed the first part of what you were saying, Gordon. Were you saying that the virtual settings were a version of an integrated one?
No, not necessarily. There are elements, particularly this site in Ottawa. Part of their virtual application was turned down, but they still have some models where they are remotely monitoring people's use. And to me, that's quite different than having an in-person site where people are there. And isn't that much of a stretch from our hotlines where people are talking to people as they use? So again, a lot more to learn there, but they wouldn't be limited at all to integrated sites.
And is there, to what extent is like authorization by the state or a local municipality even necessary for virtual?
Well, that's fascinating. It varies depending on the model. So while the safe consumption sites have as a condition community collaboration, community sessions, the public health emergency sites appear to be able to open without that requirement is not there. I think it goes without saying that in this country, the first thing we'd look for is community support. And when you think about LD 1364 and what it called for, it's really about, well, would state government permit a municipality, if they wished to do this, would the state authorize that? I don't think I rarely talk to anybody that thinks that this would be permissible. Again, we're talking now about an in-person fixed site that would ever be able to be accomplished without the support of the community. We've seen this in Providence. We're seeing it in Burlington, and we saw it in New York City, that it's really only done with when the community comes together and says, we want to do this and we want to support it.
Thanks, Tina. So this is an example of switching this up a little bit. I just retyped this where I moved the permanent versus time limited under authorization. That statutory barriers piece is a subset of that as well. So we would have authorization, which is the barriers and the models, the permanent versus the time limited. Then we'd go to the settings. Then we'd go to the scope. We have a really robust list under our original work. Potential outcomes, and then innovations and additional considerations is a thing I want to dig into next. But Jason, I see your hand.
Hi, thanks, and I appreciate the opportunity to speak here. But I think we might be digging the hole deeper than we need to here. I think we have a really great document and with Tessa's permission, I almost want to say, with some tweaking and a little bit of fixing of some details, some new things that we learn, that we should submit that. And I think that, yeah, I feel like we're going deeper than we need to for what we've been asked to do. I think learning is from our Canadian friends is going to be really, really helpful, and adding some of that into the document that already exists, I think would be absolutely necessary. But I also think that in light of the time that we have to do what we're doing, and the fact that we have a really wonderful document that captures a lot of the work that we've already done, and that the information that we have, I'm just wondering if it's necessary to go through this process.
Jason, I appreciate you asking that, and I definitely was not thinking that it was either or. I think what Tess produced is amazing, and I think a lot of it is going to get knitted into this. But what I wanted to make sure is that we were cross-checking the categories, and then with Tess's permission, I can pull in a cut and paste kind of way a lot of the content that she's produced to date into the document. But I didn't want to miss the chance to go, this was the bigger picture. Are we missing anything? So for example, some of those things about like fixed versus mobile, or maybe standalone versus integrated, it's a level of detail that I just want to make sure when we think about something that's tailored for Maine and the opportunity before us, I just want to make sure we're not missing content that should be included. I think it's both and, if that's okay with you. I mean, and
Right.
Tess.
Yeah, Rachel.
Yeah.
Rachel.
Yeah, thanks. This kind of arcs off of what Jason was saying, but I really reflected a lot after our last meeting about the conversation about strength of evidence. And Courtney, I think, brought up this really important question of, hey, just because there isn't evidence doesn't mean you don't do it. And I really, really appreciated that and thought about that for a long time. And I thought I kind of went back to the old framework of how do you, to the extent that we're using evidence, like a scientific paper, a lot of which Tess referenced, kind of what's the framework by which you look at a scientific article and evaluate its evidence? And then that can point out, here's where we have evidence and here's where the gaps are. And if that information doesn't exist, so be it. That doesn't mean you don't do it. It just means that we don't have this strength of evidence here, or we don't have the depth of evidence. So I think that sort of basic framework in scientific articles generally looks at a population. So you do the study design, but we don't have to talk about that because we're not going to get randomized controlled trials here. But what's the general population? What is the intervention? And then what are the outcomes? And they're not always transferable. This intervention for this population produces this set of outcomes, and then that gives you that amount of information that we may not have it elsewhere. And I think that speaks, I'm going to get to my suggestion for this in a second, Carol, sorry, but that speaks to the idea of, something tailored for Maine may need to be somewhat new because we know this much about these interventions for these populations to produce these outcomes. So to that end, the only thing I think actually the way you've structured this, Carol, actually lays those out beautifully. I would add maybe the word populations to settings, because scope of services is the intervention and the potential outcomes is there. But I think there's something I just even remember some of Dina's commentary about, hey, who was using this place in New York? It was the people who lived close by. It wasn't the people who lived a mile and a half away. So sorry, I'm being verbose, but I wanted to kind of put a little bit finer point on this idea of where is there evidence, where is there not evidence. It doesn't mean that you don't act on things. You just say this is just an area of new exploration. And in order to be able to articulate that framework of population intervention outcome could be really helpful.
Tess?
Thank you so much for that, Rachel. I really appreciate it. I added group agreements as a category, which is both the process of how we do our work in our meetings, but also this idea that there's, we're focused on evidence-based or evidence-informed. How about that? Because there's sometimes not evidence for things, as we know so well in public health. So evidence-informed, and then also that attuned to Maine. This could be the great place to set up we recognize we're not like every other place, and we need to come up with something that's going to work for here. Yeah, I love that.
Tess has her hand up, Carol. Tess, go ahead.
Thank you, Gordon. I, of course, give permission to use the report that I came up with. I'm also happy to help edit, write other portions of the report. This topic is within the expertise of MIRAP. It's something we're very familiar with, and we'd be happy to help. And I would be interested in, at some point, getting to what are the gaps so we can help with that research process. We have the time, we have the resources, and we'd love to help with that. In terms of something else to add, the list, it might be under either scope of services or maybe priority population and settings, looking at the difference between a medical model of having an overdose prevention center or a peer-led model. There are differences. And one thing I just kind of want to note on, we've heard a couple times of the idea of having a virtual OPC or a safe line. This is just my opinion. I feel that is beyond the scope of what our group is tasked with doing, especially if those models are probably already legal, or that's something that peers are already doing for one another, or I like, that's just my opinion. I'd love to hear how others feel about that. I just feel like I kind of agree with Jason. We're going down a rabbit hole. And if we're not tasked to actually look at those models, we're just adding time and delay for a report that, as you all know, like the advocates in our community, we don't want it to be delayed much longer.
Thanks,
Okay,
Tess.
let me mention a couple things. At the last meeting, and again, I realize that at the last meeting, Jen Gunderman, Jason, Tess, you were ill, and I shouldn't realize that, having been with you the day before. So that at that meeting, though, we went around the table to say, where are people on this? And there is no consensus. There would not be a consensus to submit, for instance, Tessa's report to the legislature as our report. There, I really feel that my role as the chair is to try to find where are our areas of agreement and where are the areas of that we, if we keep working on this, where we might achieve more agreement. I don't think it serves the legislature well to simply give them a document when half the people, enthusiastically support Maine doing this and half the people are adamantly opposed to it. So I think that I just want, particularly those of you who were not at the last meeting, I encourage you to watch the tape from the last meeting and see that discussion, because I mean that is informing my view as to where this is likely to go in the next few weeks. Given that we hope that our Canadian colleagues will join us in about 15 minutes, let me jump right to that, and then Carol can bring us back, because I think it's really important. I think what you're doing is really important. I think the issue that we're looking at is really important. I think people really care about it. But this is, I do not think we should be. I think we are just, in a way, beginning our deep dive into something that might work, and I think the legislature will ask us to keep working on this, and that they will not take our report at the end of February. So I think the likelihood for what I'm going to call an interim report, I'm sorry, because I think it will be an interim report. They'll make it an interim report. We won't, but they'll say, hey, keep working on this if you can, and give us something later in the year. And it's not just because we've got so much that we could do. It's also the fact that Providence only had their soft opening last week. It will be weeks before we're really able to see the third place in this country, the only one in New England, the only one authorized by a legislature, and see how that's going to roll out. Burlington still scheduled to open in the fall, and of course the big elephant in the room. We don't know what the new Department of Justice is going. We don't know what position they are going to take on these sites. So I really believe that when we put together whatever kind of document we're all comfortable with by the end of the month, and we put that in front of the Criminal Justice Committee, I believe pretty strongly that those 8 Democrats and 5 Republicans are going to say, well, this is interesting. Could you keep going and come back and tell us what things are looking like in Providence, Burlington, and this country, and wrap it up for us in December? I mean, I know that's a disappointment to many advocates that want to do this right now, but it's just, I don't think it's politically realistic. I don't think it's realistic from a working standpoint. Now, it would make my life appreciably easier if we just gave them a report at the end of February and I could be done with it. But I think it's too important an issue to simply, leave it. If they report out a bill, it would be, in my opinion, defeated. And then nobody could think about this again until 2027. So anyway, I've laid all my cards on the table. It's not unusual. I'm quite frequently willing to do that. Carol, get us back on. Oh, the other thing I was going to say, that I think in terms of this month, we've got a meeting scheduled for February 7th and several excellent proposed presentations. We then put an additional meeting on your schedule for February 14th. That was to review what we want to give to the legislature and still give you 2 weeks to share it with your constituents as you wanted. And then we would give them something by the end of February. And Senator, the other interesting thing 2 weeks ago was that Senator Penny Beebe Center joined us for the whole meeting and said at the end of the meeting that she would be pleased to receive our report at the end of February, and not that we shouldn't get too hung up on February 15th. So now back to you, Carol.
I appreciate that, Gordon. Tess, I did see your hand pop up. I don't know if we do have to kind of wrap up in, let's say, 7 minutes.
I can be very, very brief. I'm sorry if I was not clear. I'm not saying that we need to have the report done next week. I'm just pointing out from my perspective, if we are to go far enough deep where we're looking at just virtual models of care, which lack many of the services that you'd get from even a mobile or an in-person that you might not be able to do virtually. And I guess if we are going to keep the virtual version, which I wouldn't call an overdose prevention center, then we need to have the same scope of data available, if there is any, that we can look at to see, compare the outcomes for participants and communities. Because I think if we're going to hold that standard to anything that's a fixed or a mobile site, then we need to know if there's any connections. And I apologize if I was not clear on my comment.
No, that's great, Tess. Thank you very much. Really appreciate it. So I've added obviously for each of these settings and population approaches, we've got pros and cons for each. I'm just saying that there's always pros and cons, right? But they may not stack up evenly. And then outcomes and data. So that's just a placeholder for, we're not going to lose track of that. I did also flag that even though we said hotlines in the very first meeting as something to look at, maybe this is something that we want to reconsider. It was, in the early days, let's just say. So what I would love to do, and I see Dina and Rachel, your hands up, so I'm just going to try to blurt this out quickly, knowing that we've got our guest joining us in about 5 minutes, which is, if I send this list to you all, what we don't want to do, I'm definitely not looking to produce a report that has big gaps in it. We want to acknowledge gaps. So if there are gaps in information available to us, or gee, we reached out to somebody and never heard back, but it would be great to hear from them, whatever it is, I think we want to say all of that up front, because that also just gives us the sort of staging to do more inquiry if we get, the opportunity to do so. So I definitely don't want to leave gaps if we can avoid it, and acknowledge them when we can't. Dina, I see your hand.
What do you think about including sources of funding and types of operator?
Oh,
that's a really.
I think certainly potential sources for funding should be in our report. I'm not sure what you mean by, you could be talking about, would the ideal operator be a nonprofit, governmental agency, private, for-profit, that kind of thing.
Yeah.
Yeah, sure. That should be up there somewhere around the models, because I think most of the sites in Canada are operated by frankly, not nonprofit, non-governmental organizations, but that's something that we can get more information on. Rachel.
Real quick, thank you. One last thing I've been reflecting on the last couple of weeks is the idea of what additional behavioral health and public health infrastructure exists within a community so that the Overdose Prevention Center is able to meet its potential. There's so about, you just having a public or even a transportation infrastructure. I could say more about that, but I think both in the literature, we see examples of where that has been really helpful. I know in Dr. Kral's talk, he talked about in San Francisco, they originally set something up as sort of a referral site. There wasn't anything to refer to. And then I also just reflected from my own personal experience, like working in Waldo County. I even in a pretty robust addiction medicine practice, I really struggle with referrals and resources. We don't have a really strong public health infrastructure, in a sort of county by county, jurisdiction by jurisdiction. There's a lot of places there is an outreach and engagement. So I think it would just go up under the settings, potentially, just for the group's consideration, something about what additional behavioral health, public health infrastructure exists to support an OPC.
That's awesome. Thank you, Rachel.
It could also be touched upon, Rachel, at the section where we'll be talking about one of the potential services. One of the most important services is referrals.
Right.
I mean, I mentioned that they've done 1 million referrals to other services in Canada, testing, medical care, and if there aren't places there to refer to, we should deal with that. I want to mention two things. We'll keep an eye out for our Canadian guests. There are two potential barriers to us continuing this work. One is that we will be out of the rather skimpy amount of money that the legislature gave us to do this study by the time we produce this report. Or we'll be pretty close to it. You'll remember it was $15,000. So I can tell you that timing wise, and with the consideration of the budget, this legislature is not going to give us more money to do this. Now, I have talked to private funding sources, just anticipating we might want to continue this work. And I think there's a reasonable likelihood that we could get a similar amount of money from philanthropy to help support our continuing work if the committee asks us to do that. That's the first barrier. The second barrier is your time. You signed up at our request as volunteers for a project that was to be done by February 15th. So if we are going to continue to, and we're asking quite a bit of all of you, we're asking you to look at 100-page documents. Many of you, like Dina, have taken upon yourself to call, sites in New York City to get community input. So again, I want to acknowledge that, if the committee asks us to continue the work, that we will be checking in with each and every one of you and to see whether you can give us another 6 months. Carol.
Thank you, Gordon. Jen, I see your hand.
Jen, you're on mute.
Hi,
And
sorry, I
do
was
please-
doing it on the phone
please,
earlier.
yeah.
I didn't get to see the top of that document, Carol, and I know it's a community buy-in under other considerations and innovations. I think when I think about this evidence-based, right, it includes what the science says, local expertise and referrals, and community value social norms, all being equally important. I think if community buy-in is in its own, like community considerations is in its own topic, I think just putting it as like a sub under other consideration does not give it the attention that it needs. Because if this is really going to truly come down to what a municipality, what a community will do, that actually should be just as important as the models, the science, and the local, expertise.
Totally get it, Jen. You're totally right. And when I look at the way we outlined this originally, that's how we had it. So that's my mistake. Thank you for flagging that. Really important. So I'll pull the community considerations out into its own bucket. You're the best. Okay. What else? Are you all, is there anybody who has any other concerns? I know I took this down, but in terms of the outline itself, did anything strike you as potentially missing? And while we wait for Christine and her team to join us, you know, when we think about the last question I was going to ask you, if we had nothing but time, was, you know, tailored for Maine. What does that really mean? What are we, you know, what are those considerations? We obviously talk about our rural nature, but is there more to tailored for Maine that you all would like us to attempt to articulate in this report or to research?
Well, I think we should look at some data to help support that premise that we should be looking for something that helps, that is responsive to the issue across the state. That in fact, you know, a small point would be that fatal overdoses in Portland last year dropped by like 50%, from like 27 to 13 or something. Don't quote those numbers because those could be wrong, but it was quite a dramatic drop. Now, again, just in the city of Portland. We usually only collect our data by county. There are, so you've all, most of you are familiar with the numbers. So the decline statewide was 19%, but there are some counties that, while there were almost no counties that actually increased the number of fatal overdoses, there were some that were absolutely flat, that did not see a 19% decline. And if we can look at this data sometime. I could have Dr. Sword join one of our meetings and we can show you this on a map, that actually the places that are struggling are the rural counties, our perimeter counties, where there aren't a lot of services. And so my point would simply be, again, probably taking off my role as the chair of the group and advocating, I'd say, you know, if there was a thought that, well, we do authorize a city to have a safe use site, and if that city happened to be Portland, Maine, I would argue that it does almost nothing for the rest of the state, and that in fact, you know, we ought to look, given that some of these are expensive to operate. You obviously want a good workforce, a well-trained workforce, that we're not going to be able to have one in every county, every community. And that's why I say, I think we should look at solutions that would be mobile or virtual so that all of Maine could benefit from what are some obvious benefits of giving people a safe place to use.
Thanks for that, Gordon. That's really helpful. Do folks have other, when you think about tailored for Maine or attuned to Maine, do you have other things that you particularly were thinking or are thinking about it? And Sheriff, I know I kind of got this when you said it in a couple meetings ago. I think, I don't know if you used the word tailor, but I wonder, Sheriff, if you had something specific in mind besides the rural component.
No, nothing specific other than the challenges that you have in rural counties such as my own, with that doesn't have a availability for transportation, which is the biggest issue that we all face, and you know, the ability to bring these services to the people who really live out in the sticks, and that's where we see the majority of these issues going on. So I have nothing specific, but just generalizations.
Yeah, that's really helpful though. Thank you. Tess?
Well, do you think it would be possible for the purposes of the report where we outline what different communities in Maine might need? Because I do think that if we did have a fixed site in Portland, we're not just looking at bringing down overdose deaths. We're also looking at reducing syringe litter. We're looking at connecting people with services. And maybe that model wouldn't work in rural Maine, but I don't see why we would have to have a report that only addresses rural areas. We could have a report that looks at different models and findings, barriers dependent on population size, or maybe what their infrastructure already looks like for what they have in place. I just wouldn't want us to limit our findings to one area when this is a statewide group. We're trying to find solutions that are going to help all of Mainers. And I think there's always going to be that pioneer city or location. And we don't know if or when that would happen, but I think having options identified for different population sizes is important. I wouldn't, from the jump, limit to one area.
Yeah. Thanks, Tess. Gordon, I'm wondering if
I'm gonna call Christine.
okay. We may still be in a literal time warp if we did not get this Eastern to Atlantic time sorted out. So apologies for the delay in bringing in Christine. Hopefully she is available, indeed available and just running a few minutes late. Any other thoughts while we just give this a minute? And keep in mind, we can also pivot to a plan B, which was actually, it's more like a plan C, but it was a plan B, which is the Rhode Island webinar for anyone who's interested. Anything else about Tailored for Maine, though, before we go to the next topic? Okay. So what I will say is that if we can indeed get Christine and Megan from the Ally Center in Cape Breton to join us, I'm going to send you all a link to the webinar that we originally thought we were going to share, we were going to watch together. It's a little bit, there's like an extra step in there. I wish there wasn't, but there is, in that it's not posted on YouTube. It's actually in the New England Public Health Training Center resource section. It's not a huge burden, but you do have to give them your email address and, kind of create an account, so to speak. It doesn't take long. It's just a couple pieces of information, and then you'll be able to click through and watch the video. But so I can't give you a link directly to the video, but if we were going to watch it today, then I was thinking, okay, we won't, everybody won't need to do that. We can just watch it together. So I think I'm just going to go out on a limb here and say, why don't we just take a short break? Everybody can grab something to drink or whatever it is you need, but come back within 5 minutes, and we're either going to have Christine, or we can decide if we want to listen to the Rhode Island overview together, for anybody who wants to do that. Okay, 5-minute break. Come back at 2:15. Thanks. Any progress, Gordon? You're on mute.
No, I got her voicemail when I called, and then I tried to text, but it's a landline.
Okay. I just sent an email.
Okay,
Um,
yeah. I think probably the time zone confused them maybe, but I don't know why it would. They're obviously an hour ahead of us.
Yep.
So, no, but I think Plan B probably is the way to go. Although, let's see what anybody else would like to share before before moving to that tape.
Okay. Well, and I can also, we didn't get to the part where I gave everybody, or maybe you could, but the list, Elaine, Hugo, Colleen,
Yeah,
Rob from Ottawa.
yeah.
I think it's
No,
worth asking what folks' priorities are.
Yeah, no, we can probably take out most of the rest of the meeting, just finishing the agenda. I'll be honest with you, but you let's see how much time is left. Does it take you very long to get that set up?
No, I've got it in the queue. So,
Okay. Yeah, well, maybe we'll do like 15 minutes of discussion and then see where we're at, and then the nice thing about it, once you start it, then I actually think if you wanted to have them see the full hour, you stay with it, and I'll do the 3 o'clock call.
sure. Great idea.
Remember, the 3 o'clock call is not with content experts; it's with government people to see what we want to hear from Quebec, and that's a much different conversation.
Great.
And I'm going to say, honestly, now that I'll let them know the other provinces we're talking about, and it may not, particularly not knowing whether we're going to be, continuing to meet for 6 more months. We may not need anything from Quebec, but I'll see how interested they are in sharing things with us, and they do have that mobile van in Montreal, for instance.
Great. All right, we'll give it one more minute and then we'll come back together and make a plan. The clock just struck 2:15, so I'll call everybody back together and say that we have not successfully reached Christine and Megan in Cape Breton. Big apologies for this glitch. Gordon and I just discussed that we have 4 people in the queue for February 7th, and based on the discussion that we've had so far, we just want to make sure that we're prioritizing the folks that you in particular want to hear from. If we are not successful and it seems like we're not going to be in getting Cape Breton, we could also ask them if we felt we wanted to hear from them as well. So I think, Gordon, would you mind doing an overview of the list? And this is for everybody who's looking at the agenda. These are the folks, most of the folks that are listed at the 125 mark of the agenda.
Just give me the names, and then I'll say what I know, and then Tess can weigh in too, because she knows a couple of these people.
Sure. So we've got Dr. Heischke from Alberta, Elaine Heischke.
Oh, yes.
We've got Hugo from Portugal. We've got Colleen from Rhode Island, and we've got Rob Boyd from Ottawa.
Okay. And we've really got Roland too.
And Roland. Yep.
And he's got at least one person from Amsterdam, I think. Elaine, we don't personally know Elaine, but she was the principal. She's the associate professor and Canadian Research Chair in Health Systems Innovation at the School of Public Health at the University of Alberta. But she chaired the committee that put together this operational guidance. And she's really quite prominent in this field in Canada. And I think did she respond to our inquiry, Carol, and offered to present?
She did,
Yeah.
yes.
So she, and again, she has a very, she wouldn't be presenting from one site. She would be presenting almost, from from the research standpoint. Hugo, I'm going to ask Tess to comment. I believe that he virtually founded the site in Portugal and is really one of the real architects of the entire drug system that they have in Portugal. Tess, you've met Hugo, right?
Yep, I've had the pleasure of meeting Hugo and then also going over to Portugal to visit their drug consumption room.
He would be talking with us about primarily the site in Lisbon.
I believe so. That would be the site.
So there is a lot of Portugal almost always comes up in the top 3 or 4 countries when people talk about drug policy around the world. Who was the third person, Carol?
We talked about Colleen from Rhode Island.
Colleen, yeah. Colleen, I think she said she's available the 7th. Am I right, Carol?
That's right. Yep.
Mm-hmm. And she is the executive director of Weber Renew, which is the nonprofit organization, which resulted from the merger of 2 other nonprofit organizations, and they have the contract to do the site in Providence. And so the challenge with getting Colleen is simply that it's quite a busy time for them opening their site, but she has offered to present. I don't know that we want to take up her time if we're all able to watch the presentation with her and Brendan Marshall, who did this New England public health technical assistance thing last week, because that's really what they'd be presenting to us. Brendan Marshall is an epidemiologist at Brown, and he's got he's got a piece of the NIH grant to do research on all of them. And then Rob, he is the executive director of the site that I talked about in Ottawa that's doing virtual. And that's why Health Canada thought he'd be a particularly good one for us to talk to. He's communicated back to us. He's happy to present. And then Roland Robinson is a young man who worked for the state at the Office of Behavioral Health, worked with me for a year, and then got a fellowship to do drug policy research in Europe and in Brazil. And it's like a 2-year fellowship. It's a really good gig. And he has been writing reports, dispatches, a really great writer. He also worked for Angus King on the Hill for a short time as an intern and then permanently. That was his last position before he got this fellowship. And he has offered to present to us himself. He's also offered to have us talk to one of the site directors in Amsterdam, I believe. So those are all available to us on the 7th. And we really need to hear from you which ones you think are the most critical. Now, again, if my preference of continuing our work carries sway with the legislature or anybody else, and we actually continue our work, we can hear from all these people. But I think if I do not control this process, it's possible that we're going to give them a report at the end of February, and that's it. Anyway, that's the kind of the briefest amount of information on each of the potential people.
Thanks, Gordon. I will add that the Ottawa model, one of the reasons that appealed when we spoke with Anna Roberts, again, who works on the federal side in Canada, and she gave us these ideas. They hold a federal exemption, which is a permanent exemption, not a short-term exemption. They have an integrated model, and they have a video surveillance option. So it sounded like it checked a couple boxes for us in terms of looking at some different ideas. So I think that was part of the appeal, at least in my mind, in talking to Rob. But there's also, I just want to toss out that there's a few people we haven't pursued yet, but Anna gave us the name of someone from that site that Gordon mentioned that's 100 miles north of Alberta. It's Grand Prairie, Alberta. And so I think we could get definitely, as the sheriff said, into the, the hinterlands, talking to them about their model. So they have a much smaller city and a mobile site as well. So there's a couple other ideas there too. Tess, I see your hand. Oh, and
Yeah,
I'm sorry, Tess. We have two people in the waiting room and I can't see their names, but I suspect they're who we're looking for. So let's hope. You go, Tess.
Very quickly, I just wanted to echo that, Carol. I would really be interested in hearing from Northreach Society in Grand Prairie, because I did a little research and their population is at 65,000. So I think that could be a good location to talk with.
Okay, that's great. Gordon, let's reach out to Dalsey, whose name we were given by Anna, and see if we could get that. Before we hand the floor over to the good folks from Cape Breton, I wonder if you have other thoughts in terms of that list, and if there's a priority, if there are priorities that you all would.
Our guests have joined us, Carol.
Yeah. Hey, Christine. Hey, Megan. Thank you so much for joining us. We're just about to start. If folks could send me an email with your priorities on that list, that would be very, very helpful. So with that, Gordon, I'll turn it to you, and you can introduce our guests.
We're very excited to see Christine Porter and Megan Peters. At very short notice, they agreed to share with us their experience in operating an urgent need public health site, as I understand it is, in Cape Breton, specifically in Sydney, I believe, Nova Scotia, which is 10 hours from here, but we're hopes that someday maybe we'll be able to see it. So we're apt to have a lot of questions for you. I understand you've been operating for about 2.5 years under that particular exemption. So I don't know whether you have a presentation for us. Why don't you tell us a little bit about whatever, and then we've got lots and lots of questions. While we've read a lot, including this national operation guidance, and we've been in touch with Elaine, I don't know how to pronounce her last name, Elaine over in Alberta, who really was the primary author of worker on this. But you are actually the first site we talked to. We're in touch with a lot of other sites, but we're so appreciative of you giving us a few minutes today. We got about 35 minutes if you've got that much available. So I'm going to turn it right over to Christine and Megan. I don't even know which is which, but thank you. And we won't take time for all of us to introduce ourselves. We'll just, we've been asked by the legislature to do this, to look at these sites, do this study. We're lawyers, doctors, researchers, people with lived experience, public safety. We've got a sheriff, police chief, very diverse group of 15 people just trying to do the right thing here for Maine people. So you go right ahead.
Yeah, well, you're on the right track, pulling all those folks in. I'm Christine Porter. I'm director of the Ally Center, and
I'm Megan. I'm the operation manager of the Ally Center and manager of the OPS.
yeah, and thanks very much. I'm sorry we're late, but when you're working front lines like this thing, you get pulled in a million different directions, and I do apologize. But yeah, our overdose prevention site, actually it's a urgent public health needs site, which we applied for the exemption through that particular stream. frankly, because of the, the safe consumption site application for exemption is huge. And we just weren't really sure. The first year was a pilot. And of course, the province wasn't sure because you can't get an exemption without getting first notified that you'll have funding, right? So they never put the cart before the horse. It's always you show us you can get the funding and we'll give you the exemption. However, the province says we can't give you funding unless you have an exemption. So it was a bit of a tricky course there, but luckily we have some folks that work in government that understood that that was an impossible tax. So they gave us the letter saying that we were funded so we could get the exemption. And the exemption process for this particular stream was not that difficult, although, you have to have entrances and, things in place that different security measures put in place and all kinds of things like an AED machine. And, we're very fortunate at the Ally sector that it's a center, right? So it's an actual drop-in center when we have a full health clinic in the basement, a community health clinic. We have a needle distribution program. We give out over 1 million needles a year here in little old Cape Breton, Sydney, Cape Breton. So, we're able to really prove the need for such a site, right? It was slow rolling the first year. Meg pulled all the policies together, her and I together, and it was really a lot of trial and error at first, right? And trying to stay within the confines of those policies that we managed to do very well. And we thought that that would restrict a lot of folks from coming, having, not having as much freedom as they would like to have to do what they wanted to do. But in fact, it didn't restrict them. It made them feel safer. And so, Meg can rhyme off some stats for you from our needle exchange or our overdose prevention site. And I think you'll be quite surprised at how they rolled out, really.
Okay. Just so last year alone, we had 321 unique clients, but we have had over 10,000 uses. So in our main drug of choice in Cape Breton is cocaine. We've had 12 non-fatal overdoses. Following cocaine, our folks can cook up crack cocaine, but we don't have a space for inhalation, so they're able to cook it up. So folks bring in their substance. We don't provide substance. They have ability to test it, and kind of one of the only flaws is because 54% of our substance is non-regulated cocaine. A lot of times, if we're checking for fentanyl, you're not able to test because it is a pulse positive. So a lot of times our folks struggle with that because that's the main drug of choice, followed by Ritalin. So stimulants are the main drug of choice within our region. Of our 12 overdoses, 11 of them were cocaine related overdoses, and only one of that of opiates. We have 6 people able to come at a time. We have 3 booths. We've had, of our 10,000 folks that came in, 900 times our folks were asked to be peer assisted, so their peers could come in and help them be able to use their substance. 88% of our times our folks are injecting their substance. The rest are followed by orally or snorting it, but mainly it's by injection use.
Three quick questions. Does the municipality, does your city have to approve your site?
No.
Um,
No, they don't have to, but I'll tell you, it's really good to have, those community, like when you said you had the chief of police on, on board and stuff like that, right? It's really good to have those relationships and everybody kind of, so we did, we don't like to say community consultation. We like to say community engagement because, we feel that the rights of individuals, you shouldn't have to consult to have a public health a service to people, right? You shouldn't have to consult whether or not you can put it there or not. But it is good to be good neighbors. And so, we engaged our neighbors and our downtown businesses and whatnot. prior to, and yes, everybody was totally on board, right? And they got it, and it was the way we presented it and all the feedback we got. And, trying to ensure people that, we're going to make folks as safe as we can. Our policies were shared with everybody, which includes, there'd be no selling of drugs and sharing of, anything. It was just, straight up come in. And it's not a real clinical setting, it's a very comfortable setting, but it is clinical in the sense that, if something happens, we'll react very quickly because we do have a lot of trained staff and a lot of healthcare staff on board too, right?
And a lot of the referrals to healthcare came mainly from absence and wound care that followed through. For a lot of the time, we were able to do direct referrals to folks being able to feeling comfortable enough to be able to show them abscess that they've been hiding for a really long time. So we've been able to get direct referrals to healthcare through those. And really trying to, sepsis is really high within our region. So really breaking the stigma to being able to have those conversations.
How far do people come to visit your site? Do you have an idea? Are most people living within a few miles of the site? Do some people walk? Do you have public transportation? How do people get there and how far do they come?
Okay, so 85% of our users come from Sydney. They're right within the city, right? So we're located very close to the homeless shelter, to the local soup kitchen. Although it's not a, huge city, it's a very small city. Like I said, we have high rates of substance use here, right? We do have a very poor, extremely poor transport, municipal transportation system, buses. And they're very expensive and it takes you all day to get from one town into the city. So usually if people, like I said, we do have a community health center here, right? So if people are coming into Sydney, I don't know, to see the doctor downstairs or whatever, or the courthouse is here, if they're going to court or, then they'll pop in here. But, that's a very small percentage, really. It's mostly those that are living directly in the area. Yeah, people
Are
don't
there any-
generally like to wait to use their drugs that, get on a bus to come to a safe site. It doesn't make sense.
In our local area, the majority of shelters are high barrier. So there's no low barriers community in our community. So a lot of times people, when we're open, our hours are from 8 a.m. 9 a.m. to 8 p.m. And then on the weekends and holidays 10 to 4.
Okay, so you are open a few hours, 7 days a week.
365. Yeah, we only close it on the 25th of December.
Are there other sites like yours, the public health needs sites or safe consumption sites in the province of Nova Scotia?
Yeah. So Direction 180 operates under urgent public health needs as well, and that's in Halifax. So
4
Halifax,
hours away.
yeah, 4 hours away. It's a huge, it's a big city compared to compared to Sydney for sure. But our numbers are very similar.
Yeah.
Wow. So is that the only other site in Nova Scotia?
In the province, yeah.
Do you report your data to Health Canada or anywhere else?
So our data gets reported to the province, right? So Nova Scotia Health, as well as the feds who issue our exemption. So we have to report annually to the feds, our numbers, and quarterly to the province with a big annual report at the end of the year. Yeah.
So your time limited exemption, I think I read somewhere that maybe are they all, is that exemption, you all expire at the same time, or do you each have a different termination date and then can you reapply? Tell me about that.
Yeah, no, I think it depends on when you apply and when you get accepted, right? And then it's a year from that date. So they're definitely not all at the same time. And like I said, if we were to go for a full safe consumption site exemption, I think it's 3 years The exemption is 3 years as opposed to 1 year for
So you have to reapply each year. So you
every year.
successfully reapplied at least twice, if not 3
Yeah,
times.
yeah, the actually application is in right now as we
Fingers
speak.
crossed for a third.
And how much money does the province give you
$300,000.
annually?
Yes,
Do you get any other money from anywhere?
not for that. All the equipment is funded through our needle distribution program. So we supply all the equipment.
Yeah.
No cost to them. So there would be an extra cost if we would have to purchase all the syringes and cookers and stuff like that.
In the first year and a half, we were at 125.
Yeah, the first year and a half, that's all we had was 125,000. But we were only open for a few hours a day. Now we're open, we're open from 9 in the morning until 8 o'clock at night, right? Except for on the weekends. So we got some funding to do extended hours.
And we look at like 72 visits per day.
Yeah.
And so our region's quite small.
How much
Absolutely.
staff do you have?
In the OPS itself?
Mhm.
Yeah, so we have 3 full-time staff, Monday to Friday. And then on the weekends, we have 3 staff as well. So 6 staff.
And that doesn't include the 2 of you.
No.
Oh, gosh,
No,
no.
in our funding, the manager's position is only like 16 hours a week, or sorry, 8 hours a week. But like, because we're in the same building, that's why it works out for us. We kind of just, we're just a prize.
Do you operate a syringe service program as well, so that
Yes.
that people, when they leave your site, they can have clean syringes?
Yes, yeah.
How many? What is there a maximum of how many they can have?
No, there's no, so the OPS, the overdose prevention site, is within the Ally Center. The Ally Center's core service provision is needle distribution and disposal, right? So that's what we do. And that's when I said, we distribute over 1 million needles a year. It's through that program, right?
Yeah.
So there is no limitations. However, we do boast retrieving more needles than we distribute. So, we're balancing that out pretty good.
We also do
And-
inpatient kits as well.
Yeah.
For people who use substance of that nature.
And you get separate funds from the province or somewhere for your needle exchange.
Oh, yes,
Yes,
yeah.
yeah.
So the clinic is funded separately. The needle distribution program is funded separately, the OPS. Our housing, we have housing support programs that are funded separately. So we have about 6 different funding streams for multiple programs.
Wonderful. Well, I apologize for dominating the questions. Carol, why don't you take it from here? I'll go on mute. I got much of what I needed because I want every one of our members to be able to ask their questions as well. And thanks so much.
Thank you.
At 3 o'clock, by the way, I'm meeting virtually with colleagues of yours from Quebec province to see. We've actually seen some of the sites in Montreal and the mobile van in Montreal. So we, like I say, you're our favorite because you're the closest, but we will probably, well, you're actually not as close as I thought. We can get to Quebec City in 4 hours. But let me turn it over to Carol to moderate the rest of this. And I'm so glad, I'm so appreciative of you joining us.
Oh, our pleasure.
Thanks,
for the good
Gordon.
work.
Tess has her hand up. Let's start there. And maybe as you speak, just do a quick, who are you and what organization you're from?
Sure. Thanks, Carol. And thank you both for being here. I really appreciate the work that you do. I'm Tess Parks. I'm the policy director for a recovery and harm reduction advocacy organization. I'm also a person with lived experience and love a lot of people who use drugs. We've talked a lot about, as a group, of when an overdose prevention site opens, how the community reacts to it. particularly, community partners, if there was concerns about public safety, working with law enforcement. Can you speak to what that was like, maybe even to the point of asking the community how they felt about bringing it, and then where you've gone from there with those relationships?
So we had lots of concerns, of course, right? However, our community thankfully recognizes that there's a significant amount of substance use disorder here in Cape Breton, and lots of people have lost people. We just did a survey and asked, do you know somebody who had passed away? 95% knew somebody, right? So they were ready for an overdose prevention site, and we were very much welcomed when it first opened, right? This organization takes many directions, and we've found ourselves having to respond to the housing crisis that's happening here in Sydney, where nobody else would step up to the plate and people were actually freezing in the streets and nobody would open their doors. So we did, and we provided shelter right after we had, 150 centimeters of snow dumped on us. And so we had to remain open as the shelter for 9 months. It was the shelter. And, the people don't like the look of poverty, unfortunately. So when we had the shelter here for 9 months, and we just closed it about 3 months ago, that's when, and it had nothing to do with the OPS. It had to do with sheltering people and, people coming into work in the morning because we're right in the downtown, and people outside, drinking their coffee because we had to put people out so we could set up to do our normal operations all day. And it was really kind of an insane period of time that we had to go through just to, get people. Now, now we're offering supportive housing offsite in a little village and all kinds of tiny homes, and working with people to create housing. So we don't have to do that anymore. But it was never the OPS that ever has, and still to this day, people don't have trouble with the OPS. It was just, just too many people around. It was homelessness. We didn't like homelessness.
And quite frankly, it's one of our most well-oiled machines for programming. It's it's like supply and demand. It goes flawlessly, knock on wood.
It
So
really does. We have really good policies and you're welcome to them.
and our folks are just so grateful.
And they're just so grateful, right? They really are. And especially when you save their life, they get a little mad at first, if it was an opioid overdose and they get messed up. But anyway, they're quite grateful, and that's the main thing, right? And we love them.
Thank you so much. Yep. Great question, Tess. Thank you.
Yeah, and I think it's to say the struggle will always be, right? Because you're never always going to win over folks. You just have to know what you're doing is right and be grounded in that and stand true to who you are and what your beliefs are. And that's all you can do.
Yeah. And have a really good board of directors behind you. Get you.
Yeah.
Yeah.
Thank you. Other questions? It's a lot to think of. Lisa?
Yeah, hi, and I apologize if I missed this. My computer died for about 5 minutes in the middle, but did you say how big the community is that you're in and/or the city? You said you're next to a city?
Yeah, I forget how big. I think it's
112.
112,000 people. Yeah.
So we're a university town. So we just had a large influx of folks. For a while, we weren't even bridging the 1 point. So that's where we're now. So so that's where we are roughly.
Yeah, minus the university students, we'd be about 89,000.
Yeah.
Great, thanks.
Sheriff.
Welcome and thank you for joining us today. Just a quick question. What about security within the facility itself? Do you ever have any problems in there, people losing control? And if so, what do you all do to mitigate that?
We don't have security in the building. We had to have security when we had an overnight shelter, but it was for fire watch because we didn't have the proper fire system in. We don't have security, and you know, we've not had any problems, any issues at all. Like, you know, if people are getting a little amped a bit, then, you know, we kindly ask them to go to the chill out zone, or you know, like just go for the day and come back tomorrow. If you treat people with dignity and respect, you get it back. I've been doing this work for 26 years now, and I probably get more respect than the mayor, but it's because, you know, you treat people with dignity, kindness, and respect, and you get it back. And you know, we really don't have a whole lot of issues that would even require security. And it wouldn't make the people comfortable anyway. You wouldn't get people coming, right?
Yeah, yes, and I appreciate that. I think the reason I asked is because the last folks we talked to were out of, was it New York, I believe, and they were telling us about their, and I didn't mean security in a physical sense, or what do you do to protect others when maybe somebody loses control, that sort of thing. What avenues you have available to you? And probably the second part of that question is, have you experienced any illicit activity going on in there as far as selling drugs to other patrons or something like that? Or has it been strictly people coming in on their own volition with their own product and consuming that way?
Well, they have to bring in their own product. They're not allowed to sell. They wouldn't be allowed in if they did, right?
Right.
So, you know, attempts were made. I'm not going to lie. Attempts were made, and policies were enforced. You have to leave. You know, you get a ban. You can't come back for so many days, or, you know.
And I think what would be unique to like a ruralness of it all is so many folks are not welcome in different parts of our core downtown. So this is like mainly people's everything. It's, you know, where they have coffee, where they get food, where they see their health clinic, where they meet with their friends. So the moment the thought of being banned from a location happens, where they're feeling welcomed in that like they get a 30-day ban, and then if after that, then they're not allowed here anymore. The fear of losing out and being considered like part of their family, that a lot of times you don't see that happen again.
Awesome. Good. Thank you. Appreciate it.
No worries.
Yeah, thanks, Sheriff. That's a great question. I love the perspective. Scott?
Yeah, I was just curious, what kind of, I assume a city of that size, you must have, I'm assuming, a city police department?
Yeah, we do.
Yeah.
Yeah.
Yeah, what kind of relationship do you have with them?
We've got, you know, an outstanding relationship, and the chief of police, Robert Walsh, provided us with a very strong letter of recommendation to accompany our applications for both funding and our exemption. He's very much on board. And like I say, you know, they see all the issues related to the substance use as well, right? And they want to help in any way they can, and you know, keep people alive, and that's what harm reduction is all about.
And I think it's about having real conversations.
Yes.
You know, you're gonna have conversations, you're gonna bump heads sometimes, you're gonna be like, well, this is not how we see it, this is how our lens happens. So when you have open, raw communication, I think that's what's gonna make the best judgment. Is knowing you're coming from two different spots. You both want to make people safe, but it comes from two different lenses, and being able to be just real with each other.
Chief Walsh is so understanding of harm reduction that, you know, he won't allow it unless absolutely has to, people walk in the building uniformed, because he knows that, you know, you can trigger some trauma responses in folks and stuff, right? So, and he wants people to use the services, and he doesn't, you know,
And I think
not make people afraid.
yeah.
And I guess,
Really came into a factor as well too, having individual police that kind of our folks get to know and people know them, and then it makes it less fearful for folks to have conversations too.
Yeah, so the beat cops are really, like, you know, they're around, but they're approachable, and they're, you know, they'll stop and chat to the guys around and gals, and you know, just strike up conversations. And yeah, so there's a police presence around, but it's not anything that's makes them feel uncomfortable.
all right,
Thank
and
you.
my second question is, and thank you, is there a policy in place as to how long someone has to remain on site after they use, or?
Well, it's up to them. We do have a chill zone. We prefer people not use and leave right away. We prefer people go to the chill zone for at least 30 minutes so that we can keep an eye on them to make sure that they're okay, you know, or.
But if they're using stimulants, a lot of times they just kind of want to get up and go and come over and get their groceries or go to their appointments. So depending on the substance use, the chill zone's not necessarily used. But the benefit of us is having the drop-in center. They usually just kind of come next door anyway, so they're still with.
So they're still being watched. They're just not.
Right. So a concern of mine is people using and then getting into an automobile and driving away.
Oh, right.
No, they don't. Most don't have cars. You know,
But they could, right?
They
They could.
could,
There's no
yeah,
way.
they
getting
could.
into it,
Yeah,
right?
they
Thank
could.
you.
And to
Thank you.
speak to that, yeah, like we do have like survey, like our staff walk around and like monitor stuff as well. So if we ever thought that anything like that would happen, we would immediately just
oh yeah,
not let that
we
happen.
we wouldn't let
We
anybody.
would, we as organization, we would phone if we thought that something unsafe was happening to the community.
Oh yeah.
Thank you so much. Thank you, Chief. I see Jonathan and then Rachel, and then we're probably gonna have to let our new friends go.
Yeah, thanks for speaking to us. My question is actually kind of related to Chief Stewart's question about like a liability that you guys have or liability coverage that you have for something either going wrong in the facility or going wrong outside the facility that you all could be blamed for, if you get what I'm saying. Can you explain if that's covered or if that's a issue that you guys have discussed?
Yeah, our insurance policy covers, like, you know, we have a good insurance policy. And, you know, there is a waiver that
As soon
people
as you
sign.
enter.
As soon as people enter, they sign a waiver that we're not held responsible, you know, in case of, you know, a fatal overdose or something like that. That we're not responsible for that. They sign that waiver, and we have great insurance policy from the outside to the inside of our buildings. And I think, you know, it's expensive, but it's worth it.
There's much, you know, I mean, we have a lot of substance of choice for the majority of our folks here is alcohol. You know, we have lots of bars around, so we have a lot more restrictions to enter our OPS than folks do to go into establishment
Yeah.
where they're able to get alcohol.
Yeah, there's a lot of bars and stuff around us, so you know, with alcohol comes all kinds of other things.
All right, thank you.
Yeah.
Thank you, Jonathan. Rachel.
Hey, kind of a three-part question. First of all, thank you so much, and what heartwarming, inspiring work. Did I hear you correctly? You said you've had 12 over the 18 months, whatever, 12 overdoses.
Yeah.
12 out of like 18,000 uses. Or what was the number?
10,489 uses. We've only had 12.
Okay. So, and were those? Can you just describe? Were they stimulant related? Were they?
Yeah,
was there
11 were stimulant. 11 were stimulant. One was opiate. So the majority of the time it was over ramping and seizure-like behavior.
And what's your clinical staff on site? Or is it more of a, because the number N is pretty small, you're calling for emergency response in those cases? And did you send them out, or kind of what's the clinical staff and what's the clinical course of those overdoses?
So our clinical staff's only on until 4:30. So some of like looking at the time rate, like they're different, they vary the times of overdoses, but some of them were in the evening. So our staff's able to, so they were all non-fatal. Our staff, EMS was called for all of them because that's in our policy. They have the judgment call themselves to make the decision of whether or not they want to go. You're not allowed to enter the OPS if you don't agree to it of EMS being called in the event. So a few folks, so only one was opiate, but the Narcan's on here and ready to go. Our staff's all trained for that in the event of, because again, a lot of our cocaine does have fentanyl. It's just hard to get a real reading on that. But the majority of them were over ramping cases.
Gotcha. So you're sort of providing, well, Narcan are providing supportive care in the case of a seizure until EMS arrives.
Every time, yeah.
So 911 is called immediately.
Every time, and then
every time.
In between, anytime our health clinic is in, they come up immediately is with it. But if it's in the evening, it's our staff.
Our staff and our staff are all trained, and you know, and our staff are our peers, right?
Yeah.
Thank you.
Rachel, you said you had a three-part question, but did that actually cover all three
Those were
parts?
all three parts. Yeah, you got it.
Oh, awesome. All right, great. Well, good.
I've got one more thing. What about the mix of gender and age?
So so the majority of our folks fall within the range of 40 to late 40, like late 30s, so we're 40 and just coming into the 50. Majority of our folks are male, and 30% of our folks fall within First Nations or African Nova Scotian descent.
What was the percent of your First Nations?
It's 26.4, I think.
Okay, great. How much overwhelmingly male versus female? Is it
Yeah, I think it's like
70,
I think
30?
71% male, I believe.
Great.
Mhm.
That's
And just for comparison, in our demographic, Indigenous folks only represent 5.5%, and so we're over represent. And our African Nova Scotians, it's 3% average, and we have 3% African descent when it comes to our demographics.
It's very interesting, the difference between I mean, we're still 80% fentanyl down here, so everything's reversed with naloxone, and so it would be interesting to think about. Sometimes it's just the source. I mean, the supply and demand is that maybe there's more cocaine available and less fentanyl available, and
Yeah, and
Well, I tell you, Nova Scotia has done really, really well, especially here in Cape Breton, with making it quick access to opiate agonist therapy, right? So you could very quickly get on, Suboxone, methadone, Sublocade, the new injection. There's very little time in between for wait. When I was started this, years ago, people were like 6 months on a wait list to get methadone, and people were dying all over the place. But now, that so it seems that, a lot of the opioid use disorder is, under control, or at least, being assisted with OAT. But where we have a big gap here in Cape Breton is mental health, and not being able to treat those underlying traumas and stuff. If people are ready for treatment, it's not available to them. So people are still going to numb out. They got the opiates taken care of with methadone, Sublocade or Suboxone, but they still need to take care of that, what's bothering them, right, and numb out.
And with that saying, like 2 hours away in Truro, the drug of choice is methamphetamine. So it's really, it in the demographics really vary of how close they are to different suppliers.
Yeah.
Well,
Thank you.
thank
Well,
you.
I'm looking at the clock. Oh, sorry, Gordon.
No, I'm done. Thanks.
I'm looking at the clock, and I was going to say, I think we're right at the 3 o'clock mark, and just want to say thank you again so much for sharing your time and expertise and experience with us. Gordon, I'll turn it back to you to close things out.
No, I just want to thank you so much. And I think both the province and the state of Maine we've made great strides in the last few years. We've got we can get same day appointments now for methadone and buprenorphine, and we've got all the emergency rooms almost, doing low barrier access to buprenorphine. We've got some jails doing just Sublocade. I mean, we're doing better, but the difference in the number of overdoses is still stunning. We had a 1/3 decline in our overdoses in the last 2 years, but that still was 488 deaths, as opposed to, say, New Brunswick, which is about half the population. But New Brunswick only had like 97, and they think they're a mess over there. I say, well, so we're all doing what we can with what we have, but I'm so appreciative, we all are, of you giving us some time today, and we'll keep in touch with you.
You always have
everybody.
our solidarity. Anybody
Absolutely.
doing this work, you have our love and solidarity.
We sure do.
Absolutely, and thanks so much. And
Thank you.
all of you, I'll see you, the rest of you, I'll see you in 2 weeks, and thanks for everything. Appreciate
right.
it.
Thanks all.
Bye now.